It's okay. Picture ko na lang kayo. So all of you are supposed to be how many? 100?
120 po, Doc.
120, no? Okay, Ann, ikaw pala mag-ano na attendance. Okay. Paano ba ito mag-share? Nakalimutan ko na ulit.
Share screen po, Doc.
Share screen, okay. Can you see them?
Yes, Doc.
Okay. All right, guys. I'm with you. Kahit anong pinagdadaanan nyo ngayon, medyo mabigat ang kuan ngayon, panahon. So this is quite a unique again. We have our learning objectives for this lecture, guys. So at the end of this lecture, we are supposed to understand in development, at least, development of the liver, spleen, pancreas, and the gallbladder, describe the anatomical locations of the same organs, identify, describe their structures, including its blood supply, and learn some common lesions. Okay lang tayo nito. Hindi naman kailangan mahirap. I will not make it hard for you guys. Sino nagle-lecture sa inyo regarding embryology?
Doc Casal po, Doc.
Nag-discuss na ba sa inyo regarding liver, biliary tree, pancreatic development? Hindi pa. Tapos na? Or busy kayo? Yes or no? Anyone?
Hindi po parang specifically dun sa development kasi nag-focus sa anomalies.
So wala pa sa liver, biliary tree, wala pa pancreas?
Wala pa, Doc.
Okay, sige. I'll just give you the bird's eye view for these organs. So the liver, the biliary tree, pancreatic development actually starts during the 4th to 6th weeks. And all of these are derived from the endoderm. Liver, gallbladder, pancreas develop from endodermal. And it starts from the diverticulae coming from the endoderm. So ito yung endoderm na ito, mahaba ito eh. Ito yan sila lahat. Kung na-imagine nyo yung if you can imagine the pancake, and there will be 3 layers of pancake. Just imagine that. Ito yung embryology, no? Yung pinakataas, 3 layers of pancake. Yung pinakataas is the ectoderm. Just imagine lang, ha? And yung sa gitna, mesoderm. And yung pinakababa na layer na pancakes, endoderm. During its development stage, somehow yung endoderm, yung pinakamalalim ng pancake, medyo magiging elongate siya. Medyo magiging bola. So there will be 2 pancakes na flat, while the endoderm medyo nagiging bola. Imagine nyo yung hot cake, pancakes, nagfo-fold papuntas pababa, going to the mesoderm. Bale, pag fold niya, dahil medyo nagiging bola na yung lower pancake, tapos sa gitna ng lower pancake, parang gin-compress niya, parang kinompress. Sino imagine mo yon, yung pancakes, parang hinati ang lower pancake to the point na nahati siya. Parang naging dumbbell na yon. So imagine nyo, yung upper dumbbell is now the endoderm sa loob ng embryo, tapos yung sa labas is kasama yon yung placenta, more or less. So habang naiipit na yung sa ilalim na pancake, so ito nagiging develop na ito as the umbilical cords. To the point na ang naiiwan na lang, isipin mo yung endoderm, lumiliit na siya, it forms as a tube. Tapos yung first layer, yung ectoderm, yun nagiging skin at saka yung mga nervous system, tapos yung mesoderm, iba-ibang organs, while the endoderm, yung GIT. Imagine nyo ba yun? Hirap, no? Kung walang drawing. So habang nanipis na yung endoderm, nagiging tube na yan siya. And slowly, nagkakaroon ng diverticular formation. So pinakataas, sa part ng pharynges, pharyngeal pouches, going down, medyo nagiging bulus na ito, forming the stomach. During the early stage of the embryo, the fetal development. And at the duodenal area, nagkakaroon na yung bud formation dito. At the same time, on the opposite side. So merong anterior and the posterior, the ventral and the posterior. So I'll just give you the idea. Ito na yung sa area ng duodenum, yung endoderm, nagpo-form ng bud between 4 to 6 weeks. The liver bud sprouts first and expands ventrally. So ito, nauna muna ito on the 4th week. While nearly the same but sumusunod is also the dorsal or posterior meron siyang growth. That's the dorsal part of the pancreas. So by the way, no, para maintindihan nyo rin, ito yung endoderm coming from the mouth and going to the liver area is considered the foregut. So the foregut will give rise to oral cavity, the tongue, the tonsils, salivary glands, the esophagus, the stomach, and the duodenum. No? Thus, the extent of the foregut starts from the oral cavity and terminates at the level of ampulla bladder. This is the point where common bile duct opens in the duodenum. So I'll give you another idea of the development. So during the 5th week, nag-form na yung diverticulum dito, nag-form na ng liver, while at the same time, nagkakaroon din ng outpoaching for the gallbladder, ventral, outpoaching for your pancreas, at the dorsal sa likod, outpoaching for the dorsal pancreas. And interestingly, ito yung extension to the liver. Somehow they rotate posteriorly. Nagiging ganito ito. And the common bile duct that forms here going towards the liver rotates posteriorly and somehow fuses with the dorsal pancreatic bud. So another picture here, I'll show you. Here, the liver is being formed and there is outgrowth to form the gallbladder and the ventral pancreas. This is the dorsal pancreas, and it will rotate. This one will rotate during the fifth or sixth week of gestation. And in here, there will be fusing of the gallbladder with the pancreatic ducts. So this is now the final formation. So again, the liver sprouts at the 4th week and expands. And during the 5th week, nagfo-form na rin ito, gallbladder, pancreas, and it rotates. And it fuses. And further development on the 6th week, they have already a common linkage, CBD and the pancreatic duct. So that's the embryology of these organs. Now we go to the liver. So the liver naman, it is a peritoneal organ. And that is the largest intraperitoneal structure and gland in the human body. It weighs about 1.5 kilograms. And it lies in the right upper quadrant dito, or hypochondrium. Roughly, nakikita nyo, it's triangular in shape and consists of 2 lobes, the left and the right, separated by the falciform ligament. Later, I will describe what falciform ligament is. And there are organs associated with the liver. Pag sinabing associated, somehow nakadikit yung mga organs nito. That's why the surface of the liver is variable. So organs associated with the liver, superiorly, alam naman natin, andyan yung diaphragm. And anteriorly, andyan yung anterior abdominal wall. Sa ilalim naman ng liver mo, we have stomach, the gallbladder, the bile ducts, of course, and the hepatic flexure of the large intestine. There is the right kidney inside, behind it, and the adrenal glands. Somehow it gives impression also to the inferior surface of the liver. Behind this liver, we call that posteriorly, of course, is the esophagus, banda dito, and the esophagus naman, dumidiretso, it becomes the stomach. And median to this body, just behind the falciform, is the inferior vena cava and the aorta. It also gives impression, the vertebral column and the diaphragm behind this. So laterally, of course, you have the ribs, lower ribs, and the diaphragm. So this is just the location. We're still in the location of the liver. I know, very common ito, especially yung mga kumakain dyan ng atay. So it underlies the thoracic cage. Sometimes it's very hard to palpate this. And it conforms to the diaphragm, the dome of the diaphragm. And the position of the liver varies according to the respiratory cycles. If you inspire, if you do the inspiration, what happens to the diaphragm? And what happens to the liver? During expiration, what happens to the diaphragm? Of course, and with it also is also the liver. Inspiration, the diaphragm is contracting, so somehow the diaphragm will straighten. So the tendency of the diaphragm is to go down, and it pushes the liver down. And during the expiration, during the relaxing stage, and because of the negative pressure of the lungs, it goes up, it relaxes, the diaphragm stretches and relaxes, and the diaphragm goes up, and with it also the liver. So for the appearance of the liver, generally it's brown, reddish brown in color. And as we grow older, somehow it becomes yellowish tinge because of the fat content. Habang tayo kumakain, meron din talagang formation of fat within the liver. Generally, again, it is soft, but mostly firm. It is pliable, although depends partly on the volume of blood and fat content. The more blood inside the liver, it will cause hepatomegaly. The liver will expand, and it will be more firmer. The more fatty tissue, it will be more firmer, and the color will be more yellow. Just to inform you, the liver is completely covered by a capsule called the Gleason's capsule, and this is a fibrous capsule. Since this is a fibrous capsule, it is pain-sensitive structure. So once the liver expands, you can feel discomfort and pain at the right upper quadrant area. The gross appearance again of the liver, when discussing the anatomical position of the liver, it is also useful to consider the external surfaces. The associated ligaments, and the anatomical spaces. And I'm going to describe them later. So let's go to the surface. The liver has two surfaces. Sa taas, the diaphragmatic surface, and there is such thing as antero-superior portion. It's above front of the liver. It is smooth convex. It fits snugly beneath the curvature and under surface of the diaphragm. And this is covered by visceral peritoneal. So I'm going to show to you the drawing. Here, this is the anterior part of the liver, and anterior and superior part of the liver. It is smooth, convex. It actually fits snugly just below the diaphragm. And this is covered more or less by the visceral peritoneum. Now there is also the posterior portion of the diaphragmatic surface. Medyo ipapakli natin ini liver. Makikita mo na yung posterior view. Ito yun, posterior view na ito. So you can see here the posterior aspect of diaphragm. is not completely covered by visceral peritoneum. And this one, not covered by peritoneum, is in direct contact with the diaphragm. And dahil hindi siya covered ng visceral peritoneum, it is known as bare area of the liver. So this is the bare area of the liver. So I mentioned about the diaphragmatic surface. Now we go to the visceral surface. Yung visceral surface naman is the posterior inferior surface of the liver. With the exception of the fossa of the gallbladder and Porta Hepatis, it is covered with peritoneum. So yung gallbladder, sometimes it's fused with the liver and it's not covered with peritoneum. And at the same time, the Porta Hepatis, this is where your portal vein, the hepatic artery, and the biliary tree, the biliary ducts goes in the liver, and this is not covered with visceral peritoneum. The rest is covered with visceral peritoneum. So it is molded by the shape of the surrounding organs I mentioned earlier, yung mga organs in the inferior portion of the liver. It lies in contact with the right kidney, adrenal gland, right colic flexure, the transverse colon, the first part of the duodenum, gallbladder, esophagus, and stomach. So those are the two surfaces of the liver. And I'm going to mention again, the bare area of the liver. It is located posteriorly, lying on the diaphragm surface. This is where the groove for inferior vena cava is also located. It is closely attached to the liver. And here there is no peritoneum between liver and diaphragm. So that's the bare area of the liver. And I mentioned there are other bare areas of liver. If there is no peritoneal lining, that's a bare area. So that's Porta Hepatis and the gallbladder fossa. So I mentioned to you one of those interesting attachments of the liver are the ligaments. So the ligaments of the liver, this is this fascia or lining, but it actually is a peritoneum. Liver is connected to the diaphragm by the falciform and coronary ligaments. These are formed by the double layer of the peritoneum. The falciform ligament is broad, it is thin, sickle-shaped, and attaches to the anterior surface. This is one. This is your falciform ligament. It attaches the anterior surface of the liver to the anterior abdominal wall and forms a natural anatomic division of the liver between left and right lobe. So this is the falciform ligament. And the free edge, kasi ito, mahaba ito, naka-attach man ito sa wall. The free edge of this ligament contains the ligamentum teres. And ligamentum teres is a remnant of the umbilical vein. So again, this remnant umbilical vein, sinabi ko man kanina, that there's such thing as umbilical vein during the fetal development, and it gives nutrition to the fetus, and it goes through the liver as an umbilical vein. And if one goes maturation already upon delivery, this will be contracted and becomes a remnant, and it becomes a fibrous band as ligamentum teres, round ligament. So this is the round ligament, ligamentum teres, a remnant of umbilical vein. Again, the falciform ligament, no, It divides into two lobes, the liver, and it separates functionally. It really separates. Iba talaga ito, nakahiwalay siya. Kahit operahan ito, hiwalay ito. It can still function normally. So, maybe gusto nyo makita rin yung regarding the fetal development about the umbilical vein. So, ito yung placenta. The only way na magkakaroon ng nutrition transfer from mother to baby, fetal to the fetus, is the umbilical vein. And the umbilical vein is connected to the portal vein. And it goes directly to the system, to the inferior vena cava via ductus venosus. This is during fetus. So during delivery, pag mature na yung baby, during delivery, this is cut and this contracts. At the same time, the ductus venosus also contracts. And the umbilical vein becomes a remnant only, fibrous band. And this is what they call as ligamentum teres. Ito naman yung ductus venosus, previously patent during fetal, will become contracted also and become fibrous band. And this is also called as ligamentum venosum. And this is located and can be seen behind the liver. Now we go to the same ligaments. The liver is also connected to the diaphragm by the coronary ligaments. There are two of them, the anterior and the posterior. The coronary ligament, the anterior, ito yan ha, anterior ito, and the posterior coronary ligament. And this coronary ligament attaches the superior surface of the liver to the inferior surface of the diaphragm and demarcates the bare area of the liver. That's why in this area are the ligaments that surrounds the bare area. And interestingly, the anterior coronary ligament and the posterior coronary ligaments fuse or unite at the sides of the liver. And once they unite, they form a triangle somehow. And we call that triangular ligament for the left and for the right. So let's say the left triangular ligament is a small fold formed by the union or apposition of the anterior and the posterior ligaments at the left side of the liver and attaches to the diaphragm. In the same way, the right triangular ligament is formed in a similar fashion adjacent to the bare area, this one, and attaches to the right lobe of the liver to the diaphragm. So in addition to these supporting ligaments, they are the attachment to the body of the person. And in addition to this, the posterior surface of the liver, this way you have the inferior vena cava, is actually secured. You may note here that the inferior vena cava is closely attached at the posterior aspect of the liver. And this is where there is a direct contact with coronary or hepatic veins. And this area is actually filled with fibrous tissue. And the fibrous tissue in this area is the one that makes the main support of the liver. The coronary ligaments, the triangular ligaments are just minor. They are not really the ones that supports the liver inside the peritoneal cavity. So another ligament here is the lesser omentum. So interestingly, no, uh, the ligament of the joints is different from the ligament of the peritoneal cavity. So the lesser omentum is a two-layer fold of peritoneum which extends from Porta Hepatis here to lesser curvature of the stomach and superior portion of the duodenum. So this is the lesser omentum. And there are two parts. This is the Hepato-gastric. Kikita nyo ito. This is like a fan light, no? Very broad. And the second part is the Hepato-duodenal. And this is actually closed yan sa likod. And behind the stomach are the pancreas, the retroperitoneal area, and this is a space. The only opening here is the what we call omental or epiploid foramen, and it is situated just below the liver, and it readily admits the fingers. So the epiploid foramen, it has its borders. Isipin nyo ito butas, papunta sa lesser sac. So this is the lesser omentum. Within it, we call that lesser sac. Tatanungin ko, saan yung greater sac? Sige, hanapin nyo yan. Labas ko kaya sa exam yan? Anyway, the only entry point to the lesser sac is this epiploid foramen. This has very important surgical significance. So you can insert here two fingers. It is bounded superiorly, superiorly by the caudate lobe of the liver, inferiorly by the superior part of the liver. Behind it is the inferior vena cava, and syempre butas ito in front of this epiploid. This is not the, this is not the lesser omentum, the ligament itself that ensheaths the hepatic area, hepatic artery, portal vein, and bile ducts, the portal triad. So again, okay. Now we identify the lobes. The liver has lobes anatomically, and as I mentioned earlier, it is divided into a very big, large right lobe and a small left lobe by the falciform ligament. The right lobe is further divided into quadrate lobe and caudate lobe. And if we're going to turn this posteriorly, turn it so that you can visualize posterior. So this is the right lobe, and this is the left lobe. And the right lobe is divided into quadrate lobe, which is near the gallbladder, caudate lobe, which is beside the inferior vena cava. Actually, caudate lobe is between the fissure of ligamentum venosum and inferior vena cava. So this is fissure for ligamentum venosum and vena cava. This is the caudate lobe. And the caudate lobe naman is connected to the right lobe. And we call that caudate process. Ito, parang meron siyang tube-like appearance that connects the caudate lobe to the right lobe. We call that caudate process. Again, the quadrate lobe is near the gallbladder. So quadrate lobe is between gallbladder and fissure for ligamentum teres. So you remember ligamentum teres is the remnant of umbilical vein, remnant of ductus venosus. This is the ligamentum venosum. And the caudate lobe and quadrate lobe is separated by the different structures, the branches of common hepatic duct, the portal vein, and the hepatic artery. Okay lang kayo? Now we have hepatic recesses. The hepatic recesses are just anatomical spaces between liver and surrounding structures. They are clinical importance dahil dito yung nagkokolat ng mga fluids kung merong infection sa abdomen. Especially in ruptured appendicitis, that there is collection of pus or pancreatitis. This has a surgical significance because those who operate should have knowledge on this and have to evacuate or clean the area before closing up the patient. Now, there's such thing as subphrenic recess, no? This one. Subphrenic recess is located between the diaphragm and the anterior superior aspects of the liver here. They are divided into right and left. We have the falciform ligament. It connects to the anterior surface of the liver towards the anterior abdominal wall. It actually divides right from left. So there is a subphrenic recess for the right, there is subphrenic recess for the left. Now we have subhepatic recess, and this is a subdivision of the supracolic superior part, supracolic compartment. This is transverse colon, anything above it. So this is a peritoneal space between the inferior surface of the liver and the transverse colon. This is the transverse colon. So this area. And we have such thing as Morrison's pouch. Morrison's pouch naman, if you can imagine, I wasn't able to give you an image. So Morrison's pouch is a potential space between the surface of the liver, yung pinakalalim, pinaka-posterior, visceral surface of the liver, and the right kidney. It's actually a space that is closely abut to the surface of the kidney, right kidney. Somehow, it is a potential space, and this is the deepest part of the peritoneal cavity when supine, when you're in supine lying. And therefore, pathological abdominal fluid can collect in this area, even ascites. And radiologist who does the ultrasonologist who does the ultrasound should check on the Morrison's pouch. Pag meron siyang fluid, that means there's pathology of the peritoneal cavity. Just imagine, just remember the Morrison's pouch in full ultrasound of the whole abdomen. The ultrasonologist, the radiologist check on this area. And if there's fluid, then the ultrasonologist can make an impression that there's an infection going on or there's an ascites. Normally, it's just a potential space. Now we go to the blood circulation, the blood vessels that convey to the liver. And we have hepatic artery and portal vein. Here in the drawing, the red is the hepatic artery, and the violet one is the portal vein. So the common hepatic artery arises from the celiac. This is the celiac artery, and gives off to become the common hepatic artery. And this common hepatic artery gives off also the gastroduodenal artery, superior gastroduodenal artery. And the common hepatic artery goes at the right side, at the left side of the portal vein, and goes up and divides to right and left to the Porta Hepatis. While the portal vein naman, and by the way, the hepatic artery gives only about 25% of the blood supply to the liver, while the portal vein naman is the dominant blood supply. This portal vein supplies the liver with partially deoxygenated blood, and it carries nutrients absorbed from the small intestine. This is the dominant blood supply to the liver parenchyma, and allows the liver to perform its gut-related functions, such as detoxification. You know naman na ang absorption is not only nutrients, it can absorb also even harmful substances, even alcohol. If you drink wine, you drink beer, and it is absorbed and it is detoxified by the liver before it goes to the systemic. So from the portal vein and hepatic artery, everything here, it drains into the hepatic veins. So the venous drainage of the liver here, no, is achieved through hepatic veins. The central veins, I think this will be discussed by histology, even physiology of the liver. The central veins of the hepatic lobules here, various hepatic veins, converge as form of collecting veins, and finally becomes hepatic veins to merge and drain everything into the inferior vena cava. And these hepatic veins, there are about 2 or 3, the left and the right hepatic veins, and sometimes the mid hepatic vein separately attaches itself to the inferior vena cava. So again, the Porta Hepatis, no, it is the area of entry of the hepatic artery, the portal vein, and the biliary tree. And this is where there is bare area, there is no visceral peritoneum, so that there is direct access of these structures, the common bile duct, the hepatic artery, and portal vein. And actually they divide together, they divide into right and left primary branches. As they branch itself, they continue to branch towards the different segments of the liver. So as it branches into secondary and tertiary branches towards the hepatic segments. So you may notice here for the left lobe of the liver, there are about 1, 2, 3, 4 segments, while at the right side or the bigger, also 4 segments. And also, each of these segments has its own hepatic veins. They collect everything to merge and become a right hepatic vein. And including there's also a middle hepatic vein and the left hepatic vein. They drain as a separate function. So the hepatic veins are actually intersegmental in their distribution and function. We can isolate this. For the surgeons who are experts in biliary, hepatobiliary surgery, they can resect this part separately without damaging other segments. This is very interesting, a new anatomy that was discovered, unlike before, many years ago. Now they know the specific blood supply, then they can actually separate the segment. If there's a tumor on this side, the surgeon can remove the specific area only, saving the other parts of the liver. So, as I've mentioned earlier, the hepatic veins, no, they are closely attached to the inferior vena cava. And because it's full of fibrous tissue around it, it helps hold the liver in position. So the peritoneal ligaments, the coronary ligaments, probably give a tone but play a minor role in the liver support. Now let's go to the lymph drainage. The lymphatic vessels of this liver, specifically the anterior part of the liver, drain into hepatic lymph nodes. Kung let's say on the anterior part of this liver, they naturally drain in front and goes inferior into the nodes that lie along the hepatic vessels here near the Porta Hepatis, and also towards the area of the lymph nodes at the lesser sac beneath the liver. So many lymph nodes here, which in turn, all of them drain into the cisterna chyli. So there are afferent vessels pass to hepatic, celiac, and cisterna chyli. And also behind this, the lymphatics from the superior and posterior portion of the liver drains into the phrenic, the subdiaphragmatic area. There are lymph nodes there also. And it goes up to the mediastinal nodes, it goes to the subxiphoid nodes, the pericardial nodes, and the lateral left and right diaphragmatic nodes. This is for the superior and posterior aspect of the liver, lymphoid drainage. So much for the spleen, nakaka-nosebleed. Now we go to this, so much for the liver, now we go to the spleen. The spleen is the largest single mass of lymphoid tissue, and it is located in the left upper quadrant, deep to the ribs of 9, 10, and 11. And its long axis is along the shaft of 10th rib. And this is separated from ribs by a diaphragm and costodiaphragmatic-pleural recess. I hope you can understand the costodiaphragmatic-pleural recess. That was one of the lectures before. It is the potential space inside the diaphragm, that recess where your lungs cannot reach, but actually in opposition lang yan between the lateral pleura and the diaphragmatic pleura. Kakadikit lang yan sila. So this is the diaphragmatic pleural recess. The spleen is ovoid in shape, more or less. It has a notched anterior border. Kahit pa ito lumaki, kahit there will be splenomegaly, the notch somehow does not change. It's always there. And the lower border here extends forward as mid-axillary line. The normal spleen size, normally, no. If it's normal, you cannot palpate it. But once you palpate the spleen, by verifying the notched anterior border, it is considered enlarged. So spleen is completely surrounded by the peritoneum. There's also ligaments attached to the spleen, the gastrosplenic ligament, and gastrostomach, gastrosplenic ligament, stomach to the spleen is at the curvature of the stomach. This is where your short gastric vessels are located, including the left gastroepiploid vessels. These left gastroepiploid vessels supplies the greater curvature of the stomach. That's why it's called gastroepiploid. There's also lino-renal ligament. It's about lino, the spleen, and renal. There's a tissue that connects between the kidneys and the spleen. It carries also the tail of the pancreas. So the anatomic relations, the spleen, no, anteriorly, ito nandito yung stomach. So the anterior portion of the spleen, you have the stomach, and also the pancreas, somehow it's abuts anterior part of the spleen. Posteriorly, you have the different ribs, 9, 10, 11, and the diaphragm. And inferiorly, you have the left colic flexure, the transverse colon, and the descending colon. This is the flexure area. And the medial side is the left kidney. So these are the anatomical relations of the spleen. For the blood supply, the splenic artery is the largest branch of the celiac artery. This is the celiac artery. It gives off the left gastric artery, splenic artery, and the common hepatic artery. But the splenic artery is the largest of all, and it runs tortuously along the upper border of the pancreas towards the spleen. And it passes within the lino-renal ligament. It divides into 4 to 5 branches which enter the spleen, 4 to 5. So besides artery, it also has its venous drainage. From the spleen, you have different veins. It has a close relationship with the lateral side of the stomach. It also drains the short gastric veins of the stomach towards the spleen. And it goes with the splenic vein. And this splenic vein drains from the spleen and also upper part of the stomach, courses and joins the superior mesenteric vein. This is the superior mesenteric vein, as they join together to form the portal vein. So you now imagine that the portal vein accommodates the blood coming from the stomach, from the spleen, from the pancreas, and from the inferior mesenteric vein. Practically everything in the GIT goes to the portal vein and goes to the liver. So the tributaries of the splenic vein, the short gastric vein, the left gastroepiploid, the pancreatic veins here, and the inferior mesenteric vein. So with these vessels, we have what we call portal circulation. So the portal circulation, it is a network of connecting veins in the gastrointestinal tract. So here you have splenic vein, we have the gastroepiploids, we have the left renal veins, we have the inferior vena cava, inferior mesenteric vein, and the superior mesenteric vein, and they join together to form the portal vein. It is responsible for directing the blood from the large and small intestine, the accessory organs of the liver, towards the liver. And there is a portal pressure for this portal circulation. It's 5 to 10 millimeter mercury. For the inferior vena cava, the pressure is about 4 to 5 millimeter mercury. So there's a normal flow coming from the portal, GIT, towards the inferior vena cava through the liver. So this is what we call portal circulation. And there's also such thing as portosystemic anastomosis or portocaval anastomosis. As we know, esophagus is continuous to the stomach, and we know that stomach drains to the portal vein. And we also know that esophagus does not drain to the portal, but drains to the inferior vena cava behind. There are paraesophageal veins that goes to the inferior vena cava. So this area is somehow, there's an anastomosis in this area with veins and arteries, capillaries. So this is where somehow some relationship in the anastomosis, portosystemic anastomosis. We have also the anus. We have known naman the anus. The anal part is the systemic because it goes to your iliac vessels. And also the rectum is connected to the anus somehow. And we know that rectum is closely, it drains to the portal vein. And there's a relationship here. And this is the anastomosis between portal and systemic. And we have also, we remember I mentioned about the round ligament and the falciform ligament. And the falciform ligament is connected to the anterior abdominal wall and to the umbilicus. We know that anterior abdominal wall has a systemic circulation, while the round ligament connects to the liver, and it is more or less portal circulation. So this area is also, the paraumbilical area is also has portosystemic anastomosis. And we also have retroperitoneal. It may be small, very small. It may be scattered. And you remember the intrahepatic patent ductus venosus. Intrahepatic, there is a remnant. We call that the ligamentos venosum. Remember kanina? And if this patent, it did not contract, this can be a possible portosystemic anastomosis. So the normal portal pressure, just a reminder, is 5 to 10 millimeter mercury. So if you have portal hypertension, this is above 10 millimeter mercury. So it can be 11 to 12, it can be 15. So what happens to this? If there's portal hypertension, the veins here will enlarge, connecting to the paraumbilical, the veins here connecting to the esophageal, the veins here at the anal will also enlarge, and there is direct flow from portal to the systemic. Probably you're familiar with cystosomiasis, and if you have cystosomiasis of the liver, there is fibrosis of the liver. If there is fibrosis of the liver, this portal circulation will have a hard time, will have difficulty passing through the, the liver, and the tendency there is damming of the liver, collection of damming of blood within the portal circulation. Um, More blood will accumulate in the portal circulation to the point that the pressure may reach 15 millimeter mercury. What happens to this? Once there is portal hypertension, the portal hypertension will enlarge the anastomosis area. And we know that the blood coming from the GIT is still toxic. It needs to be detoxified by the liver. If it's not detoxified, then this blood will go into the systemic circulation. And what will happen? You will have a problem in the patient, and that's why there is such term as a liver failure already. All right. So now we go to biliary system. We're past 1 hour already. Sunod na lang lecture ng iba, we'll proceed with the biliary system. And the biliary system consists of the gallbladder. We have biliary tracts, the biliary tree. This is the gallbladder. The biliary tree is the cystic duct, the hepatic ducts, common hepatic ducts, right and left as it branches. And it has a common bile duct where the cystic duct and the hepatic ducts converge. And the common bile duct goes and joins to the pancreatic duct. So now we go to gallbladder. The gallbladder is small, it is spear-shaped. It is located below the liver. This is again the gallbladder. It's located between the right lobe and the quadrate lobe, remember? And its length is about 6 to 10 centimeter. The diameter is about 2.5 to 4 centimeter. It depends on the content. The more bile, the bigger. So the capacity is about 30 to 50 ml. And there is such thing as the surface projection of the gallbladder once you partake. And this is the fundus of the gallbladder, the Murphy's point. The function of the gallbladder, it concentrates and stores bile. It is clinically important. You've heard about cholecystitis, but if you think about the function of the gallbladder, it is not essential. So we can remove it. So for the gallbladder, it has 4 parts: the fundus, the body, the neck, which is more or less S-shaped, and there is the neck joins the cystic duct, and there's such thing as infundibulum, and the infundibulum is the tapering area of the gallbladder. Tapering area of the gallbladder sometimes forms an angle, extreme angle, and it forms a pouch, a Hartmann's pouch. Clinically, this is where your stones are collected and enlarged. The cystic duct attaches the gallbladder to the common bile duct. Internally, no, you heard about spiral valves of Heister. The spiral valves of Heister is located inside the cystic duct. It is actually it's only a fold or valves in the proximal mucosa of the cystic duct. Probably serves to keep the duct patent. No? So they're just folds, but they call it spiral valves of Heister. There's such thing also crypts of Luschka, and crypts of Luschka is found within the walls of the gallbladder. They are mucous membrane uh, indentation sa loob, no? The internal surface of the gallbladder, the inner wall of the gallbladder. And they are named after a German anatomist, Dr. Luschka, Hubert Luschka, crypts of Luschka. So again, they're mucous membrane indentations. Let's go to the biliary tree. The cystic duct is very, very small. It's about 2 to 3 millimeter in diameter. Kasing laki lang ng matchstick, even smaller. 2 to 3 millimeter diameter and about 2 to 3 centimeter long. So this cystic duct is connected to the common hepatic duct. The common hepatic duct naman is about 3 to 5 centimeter long. And the diameter is also about 3 to 4, 3 to 5 diameter, 3 to 5 millimeter in diameter. The cystic duct and common hepatic duct converges to become the common bile duct. The common bile duct has 4 parts. So there is a supraduodenal above the duodenum, retroduodenal, that means behind the duodenum, and infraduodenal, it's below duodenum, and once it goes to the wall of the duodenum, it becomes intraduodenal. The clinical implications here is the identification of identification and the location of any abnormalities, particularly stone. So the stone can be located supraduodenal, retroduodenal, infraduodenal, or intraduodenal, primarily within the ampulla vater. Ampulla vater, this is where CBD, common bile duct, and major pancreatic duct and Wirsong converge. So this is the ampulla vater. So the duct of Wirsong is named after Dr. George Wirsong. He was the one who identified the anatomy of the duct, including the embryology. There's such thing as the, okay, now we go, I'll just discuss later the pancreas. Now we go to the blood supply of the gallbladder. Gallbladder is supplied by the cystic artery. The cystic artery comes from the right hepatic artery, not left, but right. Although there can be variation in this, but commonly it's right hepatic artery. The cystic artery arises from the right hepatic artery. And we have also the Calo triangle, the hepatobiliary triangle. And the hepatobiliary triangle is named after Calo, Dr. John Francos Calo, in 1891. He was the one who discovered this and named this under his name. The clinical significance of this triangle of Calo is the location of cystic artery here. This is the surgical implication here, that we have to dissect this first before anything else. So what are the boundaries of this triangle of Calot? Medially, it is the common hepatic duct. Laterally, it is the cystic duct. Superiorly, it is the inferior edge of the liver. I said the clinical significance there is the content of that triangle. The content is where the cystic artery is located. And one has to learn also the difference between the cystic artery and the right hepatic artery. Because one of the surgical complications here is if we fail to identify the cystic artery and we identify the right hepatic artery as your cystic artery, and it will cause a problem, ischemia to the liver. It may not cause immediate problem because the hepatic artery gives off only 25% of oxygenation, 25% of the blood. The main talaga is the hepatic, the portal vein. But there's a surgical implication here because it can cause massive bleeding if we fail to properly identify this. So again, the triangle of Calot, the medial, the common hepatic, lateral, cystic duct, superior, inferior edge of the liver. The content is the cystic artery. So what are the cystic veins? Cystic veins flow directly through the gallbladder fossa, directly to the liver. And it's part of the tributaries of the portal vein also. There is no specific cystic vein here, but there are many tributaries or veins that just goes with the tissues, the mesentery of the gallbladder. So I'm going to correlate this with the cholangiogram. Cholangiogram is injecting a dye through the biliary tree, cholangio, bile. So cholangiogram is the dye. So DYE, the dye was injected into the biliary tree. It's either a T-tube was inserted during the surgery and injected the dye. And you can see here, common hepatic duct, there's the right hepatic duct and the left hepatic duct. You also observe that it's continuously connected. There is no feeling defects. If there are feeling defects, that means you cannot visualize the other branches or you cannot visualize the duodenum, the small intestine. Injecting a dye and unable to visualize the other parts would mean there's an obstruction. Possible cause, stone or tumor. Here's another example here. A dye was injected, and somehow there's a feeling defect here, but a dye was able to pass through. But since there's a feeling defect, we can assume that there's a stone here, but not completely obstructing. Then it has to be removed. So our clinical conditions that we would like to share is the liver cirrhosis, the common conditions only. Liver cirrhosis and acute cholecystitis, the calculus. As we know, liver cirrhosis, I hope it was, a lecture was given to you already. Oh, not yet, no? Liver cirrhosis, wala pa siguro. So liver cirrhosis is just a late stage of scarring or fibrosis of the liver. So comparing to this one, it's smooth, and comparing to this, na meron siyang lobulations and whitish at the surface of the liver. It generally indicates there was scarring. There's scarring going on. There's fibrosis. And this is caused by many forms of liver diseases. It can be infection, let's say hepatitis. It can be chronic ingestion or beer or chronic alcoholism. So each time our liver is injured, whether by disease or excessive alcohol consumption or another cause, it tries to repair itself. It's just like a skin. Kung palagi kang may katul-katul dyan, magkakaroon ng scarring yan. Palagi nasusugatan, may scarring yan. And the same thing will happen to the liver. It will cause fibrosis to the liver. In the process, no, the scar formation can be a progressive if this is not checked. Repeated hepatitis, you do not correct your intake of alcohol. You may be enjoying the alcohol. You may be enjoying your life, drinking. It gives, wow, sarap. Sarap uminom. But in the end, it actually causes damage to the liver. Kaya mga kapatid, mga anak ko dyan, kung sino umiinom, no? Huwag na kayong uminom because this will cause a problem later. And once there is fibrosis of this liver, what happens? As I mentioned earlier, yung blood cannot pass through anymore through the liver. Yung blood will accumulate within the portal circulation. Yung liver, you cannot anymore produce good antibodies. It cannot produce glycogen or production of glucose or protein production. It cannot anymore. And eventually you will have decompensation of your GIT, of your liver. And so once you have this, cirrhosis can result to decompensation. It can be life-threatening. That's why, as much as possible, let's love our liver. Ano sabi ni Robin Padilla? Liver or lover? Now we go to the effects of liver cirrhosis. This is liver cirrhosis. We have portal hypertension. Once you have portal hypertension, you distend the veins, everything inside the abdomen. So much pressure in the portal circulation that the liver can be enlarged, the spleen can be enlarged. Because of the anastomosis at the umbilical area, you have caput medusae. Because of the portal hypertension, you have distended veins of the esophagus. We call that esophageal varices. Once you drink so much to the point that these esophageal varices can rupture. And once it ruptures, you have gastrointestinal bleeding. And this will become life-threatening. There's such thing as hepatic encephalopathy. The hepatic encephalopathy is because you have caput medusae, there's portal systemic shunting already. Blood goes to the systemic directly. There's no more detoxification. And this blood going to the systemic circulation can be toxic to the body, and you will have hepatic encephalopathy. And because there's obstruction here, you will have jaundice and elevated liver enzymes. So that's the portal hypertension. Now we will discuss about the abnormality of the gallbladder. This is the normal gallbladder. It's thin and small, but if you have inflamed gallbladder, we call it acute cholecystitis. Acute cholecystitis. There's inflammation of the gallbladder that develops slowly, and usually because there's a gallstone here, gallstone, and it can obstruct the cystic duct. And once it obstructs, the caustic effect of the bile can actually irritates the mucosa of the gallbladder, causing edema, and the progressive edema can become an infectious process. And we have cholecystitis. Here, a good example again, the formation of the stone. If it's small, it's even more dangerous. It's better to have big stone than small, but of course they're all the same. A small stone can pass through the cystic duct and is very, very painful. There are times the small stone can pass through into the common bile duct and goes down. Once it goes down, it impacts there. Once it is impacted, you have complete obstruction of the biliary tree, and this will enlarge. And the accumulation of bile, which should have been normally flowed into the duodenum, will be accumulated here and will go back to the liver, and you will have extreme jaundice. And we have already extrahepatic biliary obstruction due to gallstone. Stone in the gallbladder, we call that cholecystolithiasis. Stone in the common hepatic duct, we call that choledocholithiasis. Okay? Now, another case here, if the stones are so many, it can accumulate in the CBD and even pass through the ducts, the pancreatic ducts. And if there is obstruction also in the flow of the pancreatic duct, pancreatitis can happen. And as you can see here, normally the pancreatic enzyme should pass through the duct of Wirsung towards the duodenum so that it will facilitate digestion. But because of the obstruction, it can remain in the pancreas, and this is toxic, and it will digest itself. And it will just go out to the pancreas and will cause digestion around the pancreas and including the fatty tissues around the abdomen. And we call that acute pancreatitis due to stones, gallbladder stones. So, guys, are you still there?
Yes, Doc.
Yes, Doc.
Yes, Doc.
Ano, nakakalito na? Gusto nyo pahinga? Okay, I'm going to request, if it's okay, Anne, are you still there, Anne?
Yes, Doc. Yes, Doc.
Pwede pa ba tayo mag-lecture kahit isa na lang? And I'm going to give some pointers. Okay lang?
Okay, sige po, Doc.
Okay. Our last discussion will be pancreas. And we're going to discuss some interesting points before the bi-monthly exam. All right?
Okay po.
Okay. Any questions? Nantok na kayo? It's already 6 o'clock. We have a few more slides, but we're going to have another lecture. I'm going to request Anne again to coordinate with you so that our last lecture, pancreas, and discussion with some points in preparation for your exam. All right? Okay. Thank you. And
Thank you, Doc.
pahinga muna tayo. It's 1.5 hours already. Hindi pa tayo tapos kasi. Okay. Good evening to everyone. Stay safe, wear mask, practice social distance, walang sigarilyo, walang inuman. Kuhan muna tayo, mag-social gathering lang muna tayo sa Zoom. Thank you guys, and by the way, Happy New Year.
Happy
Thank
New Year.
you.
Happy New Year, Doc.
Happy New Year.
Thank you, Doc.
Okay, I'm going to end now. Thank you.
Thank you, Doc.
Thank you, Doc.